Hello everyone, welcome to the lecture on lower GI disorders. In the previous lectures, we covered an overview of the GI system, upper GI, and liver and pancreas. These are the learning objectives for this lesson. These are the disorders that we will cover. So let's start with C. diff. C. diff is a gram-positive spore-forming bacterium. We see this very commonly in the healthcare system. It's caused by, it causes inflammation of the colon, most commonly after like antibiotic therapy, because antibiotic therapy with broad-spectrum antibiotics tends to disrupt the normal intestinal flora. And this allows C. diff to overgrow and release toxin A and toxin B, which basically damage the intestinal mucosa. Remember the mucosal lining that helps protect our GI system and causing inflammation, cell death, increased fluid secretion, and the formation of characteristic pseudomembranes. Now, common risk factors include, as we mentioned, recent antibiotic use, hospitalizations, advanced age, immunosuppression, chemotherapy, and previous C. diff infection. Patients typically present with watery diarrhea, has mucus in it, abdominal cramping, nausea, and fever. Severe cases may progress to dehydration and electrolyte imbalances due to the, loss of fluid and toxic megacolon, bowel perforation, sepsis, and even shock. Diagnosis is made through stool testing for C. diff toxins, lab studies showing leukocytosis and dehydration, and occasionally imaging or endoscopy. Treatment includes stopping the causative antibiotic, administering oral vancomycin or fidaxomicin, and providing fluid and electrolyte replacement. Now, recurrent infections may require fecal microbiota, we call it microbiota transplantation. Basically, it's a fecal transplantation. You take another fecal sample with the good bacteria and we transplant it into the patient. I know it sounds gross, but it actually works pretty well. Major complications include pseudomembranous colitis, toxic megacolon, bowel perforation, sepsis, acute kidney injury, and recurrent infection. This can occur in approximately 20 to 30% of the patients. Appendicitis. This is a common acute condition, especially in young adults. It affects about 10% of the population, and it involves inflammation, infection of the vermiform appendix. The pathophysiology usually begins with an obstruction of the appendiceal lumen by a fecalith, gallstone, or foreign matter, and this leads to fluid buildup and rapid proliferation of microorganisms because there's fluid sitting there. And as the appendix swells, the internal pressure compresses the blood vessels in the wall. This causes ischemia and necrosis of the wall. And if this pressure is not relieved, the wall can become gangrenous. And eventually it will rupture, releasing the infected contents from there into the peritoneal cavity, which is not a good thing to happen. The clinical progression of signs and symptoms typically starts with general pre-umbilical pain and nausea, which eventually will localize to the lower right quadrant with significant tenderness at the McBurney point. Systemic indicators of the infection include low-grade fever and leukocytosis. Notably, if the appendix ruptures, pain may subside temporarily as the pressure is relieved, but it reoccurs as a steady, severe pain due to the peritonitis, because remember, if it ruptures, all the contents go into the peritoneal cavity, causing peritonitis. Diagnosis is primarily done through clinical examination of the localized, tenderness and lab tests confirming active inflammation. Standard treatment involves surgical appendectomy, removal of the appendix, and administration of antimicrobial drugs to prevent worsening infection. Delaying the intervention can lead to life-threatening complications like localized abscess or generalized peritonitis. Signs of spreading infection and potential systemic shock include rigid, board-like abdomen. It's very rigid, like a board almost, and tachycardia and hypotension. Intestinal obstruction is also another lower GI disorder that we tend to see quite a bit in healthcare, unfortunately. This, is characterized by the lack of movement of the intestinal contents, right? So there's no peristalsis, it's not moving forward, there's a blockage there through, in the digestive tract. This can occur due as an acute medical emergency, or it can also develop gradually over time. These obstructions, manifest in two primary forms: mechanical obstructions, resulting from physical barriers like tumors, adhesions, hernias, or volvulus, and functional obstructions, often called paralytic ileus, which is very common, commonly heard in healthcare. This is where the peristalsis stops, it ceases. And this happens because of neurological impairment, such as, following abdominal surgery or spinal cord injury, because of anesthesia or spinal cord injury and the lack of, nerve communication. Now, the pathophysiology involves a progressive sequence of events. Basically, gases and fluids accumulate proximal to the blockage, because remember, now it's not passing, right? So there's a blockage. And this causes intense in the intestine to distend, and the body responds with increasingly strong contractions, right? Now it's like, okay, come on, let's move, The pressure makes the intestinal wall very edematous and persistent vomiting, because if it's not going out one end, it's got to come out the other, right? So vomiting leads to critical loss of fluids and electrolytes, resulting in hypovolemia. If the blockage is not removed, the lack of arterial blood supply to that area can lead to ischemia and necrosis. Now, signs and symptoms differ by location. A small intestinal obstruction, patients will present with sudden, severe colicky pain, audible, what we call borbigmy, like sounds, and rapid vomiting, while large intestinal obstructions will develop more slowly because they're further down, with constipation and mild pain that gradually gets worse. Now, in cases of a paralytic ileus, bowel sounds are notably absent, or decreased, and the pain is typically steady rather than colicky. So diagnostics rely on clinical examination of the bowel sounds and imaging. For example, if you hear the bowel sounds in the, above the area, and you don't hear any bowel sounds below that area, then there must be some blockage there, right? Because there's no movement underneath it. Now, so in diagnostics will be through X-rays or with barium or CT scans to outline structural abnormalities. Treatment focuses on resolving the underlying cause, managing fluid replacement to prevent shock, and utilizing suction, decompression, or functional obstructions. Basically, we connect the PEG tube to a suction machine on the wall and basically empty it out, so to prevent further irritation and damage. Now, failure to intervene can lead to grave complications. This includes gangrene, perforation, generalized peritonitis. This can result in life-threatening sepsis. Diverticular disease. This refers to the development of diverticuli, which are herniations or outpouchings of the mucosa through the muscle layer of the colon wall. This occurs more frequently in the sigmoid colon. This condition is primarily divided in two states. You have diverticulosis, which is generally asymptomatic, with multiple diverticula present, and diverticulitis, the other one. This involves active inflammation and infection of these pouches. Pathophysiologically, diverticula form at structural gaps in the circular muscle where blood vessels pass. So when an intraluminal pressure increases there, often due to aging or low residue, like low fiber diets, these weaker areas bulge outward. Now, diverticulitis specifically develops when the stasis, the lack of movement there, leads to trapped feces in these pouches, the pouches that are out there, triggering irritation and infection. Clinically, though diverticulitis often remains silent, clinically, even though diverticulosis often remains silent, Diverticulitis is marked by lower left quadrant cramping, tenderness, nausea, and fever due to the inflammation and pressure. Diagnostics will include lab testing to show leukocytosis, imaging such as radiographs with contrast, barium enemas, sigmoidoscopy, because that's where it's commonly found, or colonoscopy to visualize any structural abnormalities. And it is treated, you know, basically depends on what kind it is. If for diverticulitis, treatment is preventative, focuses on increasing dietary fiber, avoiding seeds or popcorn that might become trapped in there. In contrast, acute diverticulitis will require bowel rest through reduced food intake and the administration of antibiotics. If it's left untreated, complications can include intestinal obstruction from swelling and scarring, or a rupture leading to abscess formation, or life-threatening generalized peritonitis. Now let's talk about gastrointestinal bleeding, GI bleed. This is a critical manifestation of different types, a wide variety of digestive disorders, ranging from chronic, hidden loss to life-threatening emergencies. Pathophysiologically, bleeding can result from vascular erosion in conditions like peptic ulcers or gastric cancer, where lesions destroy the mucosal barrier and eventually erode into the blood vessels. Because remember that lining protects us, right? And so if that lining is, eroded or, breaks through it, then the next layer is where all vessels are. Now, in patients with cirrhosis, portal hypertension can lead to formation of distended, fragile esophageal varices that can easily rupture and cause massive hemorrhage. Furthermore, severe inflammation in conditions like ulcerative colitis causes bleeding from the ulcerated tissues. This situation is often worse in liver disease due to the impaired production of the clotting factors we need, right, that the liver helps with, like prothrombin and fibrinogen. So the signs and symptoms of a GI bleed depend heavily on the location and severity of the hemorrhage. So hematoemesis or vomiting blood will appear like coffee grounds. And this is due to like the partially digested, blood or stomach acid. And if the hemorrhage is fresh and extensive, then it'll be bright red blood. Significant bleeding higher in the digestive tract often presents as melena, dark tarry stools, while frank red blood typically indicates an undigested lesion in the rectum or anal canal, like even in cases of hemorrhoids, right? You'll see bright red blood. Chronic small-scale bleeding often shows as, iron deficiency, anemia, acute hemorrhage triggers, hypovolemia marked by low pressure, pallor, or rapid weak pulse. Diagnostics utilize the Guaiac test for occult hidden blood, fiber optic endoscopy for direct visualization of the source of the bleeding, and barium radiographs to outline structural abnormalities. And treatment will focus on immediate stabilization, basically fluid and electrolyte replacement to address the hypovolemic shock, alongside pharmacotherapy using H2 blockers or proton pump inhibitors to reduce acid and promote healing of the mucosal lining. In cases of liver failure, supportive measures like clotting factor replacements or albumin transfusions become extremely vital. And then without any intervention, complications can be fatal and include circulatory collapse or hepatic encephalopathy, which occurs when the indigestion of food, highly concentrated in protein, can cause toxic surge in serum ammonia. Now let's talk about chronic inflammatory bowel disease, IBD. IBD encompasses two primary disorders. You have Crohn's disease and you have ulcerative colitis. While both of them have high familial incidence, like their pathophysiology differs in tissue involvement. Crohn's disease is characterized by skip lesions or transmural inflammation. This affects all the layers of the intestinal wall. This often results in a thick, rigid appearance and cobblestone mucosa. And it most frequently affects the terminal ileum. Ulcerative colitis, on the other hand, involves continuous inflammation, generally restricted to the mucosa and submucosa, starting in the rectum and progressing proximally, which interferes with vital fluid and electrolyte absorption. Clinical signs and symptoms are, marked by periods of exacerbation and remission. Crohn's disease typically presents with soft stools, like lower quadrant cramping, often leading to significant malnutrition and malabsorption. Ulcerative colitis is distinguished by frequent watery stools containing blood and mucus, often accompanied by tenesmus, very painful rectal spasms, and extensive bleeding. This results in iron deficiency anemia. Diagnostics include direct visualization to a what we call sigmoidoscopy or colonoscopy, and imaging can reveal a string sign in Crohn's patients. Treatment focuses on reducing inflammation through either sulfasalazine or glucocorticoids, steroids basically, nutritional support such as total TPN, total parenteral nutrition, to give the bowel a rest. This actually is used during severe episodes, and surgical resections like an ileostomy when necessary. Fatal complications depend on the disease type. Crohn's transmural nature often leads to fistulas and abscesses, while ulcerative colitis carries a risk of toxic megacolon and has a significantly higher long-term incidence of colorectal carcinoma. Irritable bowel syndrome. This is a widespread functional gastrointestinal disorder affecting about 20% of the global population, particularly young and middle-aged women. The pathophysiology is, multifaceted basically. It involves abnormal motility, where transmit time is either too fast or too slow, and visceral hypersensitivity, which increases the pain perception. Other contributing factors include post-infection, infectious inflammation, and overgrowth of intestinal flora, leading to excessive gas, psychosocial stress, and food hypersensitivities. Clinically, IBS manifests as lower abdominal pain, bloating, and gas alongside altered bowel habits such as diarrhea, constipation, or an alternating pattern of both, right? It's not consistently either diarrhea or constipation. They both alternate. A key characteristic is that these symptoms, including fecal urgency and sensations of incomplete elimination, typically subside after defecation. So diagnosis focuses on clinical signs using the Rome criteria and exclusion of structural or metabolic issues like food allergies, infections, or lactose intolerance. Because there is no cure, treatment is individualized, focusing on dietary modifications like fiber supplements and removing triggers. Pharmacotherapy may include laxatives, antidiarrheal drugs, antispasmodics to help with the spasms and pain, and antidepressants to balance serotonin levels. Now, for women specifically, medications like olosterone and lubiprostone may be used to regulate colon activity and fluid secretion. Now, while IBS does not lead to structural damage or serious physiological complications like cancer, it is a complex condition that can significantly impair a person's quality of life, right? Often requiring like a interdisciplinary team approach for effective management. Peritonitis. This is a critical, life-threatening inflammation of the peritoneal membranes, commonly arising from either chemical irritation such as enzyme from pancreatitis or chyme from the perforated ulcer, or direct bacterial infection from a ruptured appendix. The pathophysiology is marked by a sequence where the body initially attempts to localize the infection with a thick, sticky exudate. However, as the inflammation spreads, the highly vascular membranes undergo massive vasodilation, and this can lead to third spacing, right? It's a dangerous shift of fluid, protein, and electrolytes from the blood into the peritoneal cavity. This results in severe hypovolemia because now the fluid is not going, and the electrolytes are not going into the cells or not in the vessels. They're in this third space, like the peritoneal cavity, just sitting there where they shouldn't be, right? And this can cause also the peristalsis disease, and this is known causing paralytic ileus. Clinically, the presentation is a sudden severe pain characterized by constant generalized abdominal pain and the classic board-like rigid abdomen caused by the reflex muscle spasm. Now, as the patient enters the hypovolemic shock, they will exhibit tachycardia, hypotension, pallor. And other systemic signs of infection will include fever and leukocytosis. Diagnosis relies on clinical examination of abdominal rigidity, lab tests to assess electrolyte imbalances, and identify the underlying perforation or obstruction. Treatment is a medical emergency, requires surgery to repair the primary cause, massive doses of antibiotic, antimicrobial drugs, and aggressive fluid replacement to stabilize the patient because now the fluid is in the third space and not in the vascular system or the tissues, which can cause severe hypovolemia. If not resolved quickly, the condition can progress to fatal septicemia or lead to the formation of fibrous adhesions that can cause mechanical intestinal obstructions later in life. Finally, we're going to talk about bowel perforation. This is a critical medical emergency involving a breach through the entire wall of the stomach. The small intestines or large bowel typically occurring as a secondary complication of conditions like peptic ulcers, appendicitis, diverticulitis, or intestinal obstructions. The pathophysiology follows a progressive sequence of tissue damage, where lesions or pressure-induced ischemia lead to necrosis in a complete breach of the intestinal wall. Now, this allows digestive contents, when it's open and perforated, including chyme, bile, and fecal matter, to leak into the sterile peritoneal cavity, and initially triggering chemical peritonitis that quickly evolves into bacterial peritonitis as the intestinal wall becomes more permeable to enteric bacteria. Clinical manifestations are typically sudden, severe pain characterized by constant generalized abdominal pain and a classic board-like abdomen and rigidity due to the muscle spasms. In case of a ruptured appendix, pain can subside temporarily as the pressure is relieved, but it can start again, steady severe pain once the peritonitis spreads. As the condition advances, systemic signs like shock appear, such as tachycardia, hypotension, pallor. This can be accompanied by fever and leukocytosis. Diagnostics heavily are based on clinical assessment of the tenderness and rigidity, lab tests, and imaging to identify the cause. Treatment is an immediate priority. It's a medical emergency. It requires emergency surgery to repair the perforation and drain the area, alongside massive doses of antimicrobial drugs and aggressive fluid replacement to combat the hypovolemic shock. Without rapid intervention, complications are life-threatening and can include septicemia, sepsis, circulatory collapse, and the formation of those same fibrous adhesions, which can lead to future obstructions. And that is it for lower GI disorders and our series of 4 lectures on the GI system.